Hello, viewers. This is Dr. Kim Se-jin. This is case discussion to discuss challenging cases, and we have invited masters to share solutions to the problems. Dr. Kim Kyung-won, Yang Seung-min, and Park Jong-hyun. Nice to see you all. Hello. Let's see today's case. 62-year-old female, no prior history as a PDH for number 36 and 37. She had implants and she came because the prosthesis was moving and there was bleeding on the gum on 37 and 36. There was dissemination, and for 36 and 37, for 36 crown and the 37 implant, it's all failed, and number 36 and 37 were removed to use the abutment again. So the inquiry is as follows. I have not much experience of implant, as I have no experience at all with GBR. So this is my question. For number 37, can I place single implant? And if it's possible, what will be most predictable socket preservation method? Now, using BioOS collagen and BioGuide, or Osborne collagen, the xenograft plug type. So what is the difference between number 1 and 2? And the third question is, if there's any way to place single implant on number 37, let me know. So what do you think of this case? Now, looking at this case, I believe rather than doing bone graft looking thoroughly on the case is more important. Looking at the x-ray to see whether I can use the residual bone. Even if you create the bone, it's better to use residual bone that has better quality. So if you extract implant in number 36, it will be very simple case. You wait few months and deliver implant, then you don't need maybe bone graft. But if number 36, the patient do not want to remove it, still, after extracting, if you wait for 2 months, and as I indicate in the panorama, if we place implant leaning toward the residual bone for the internal conical type implant, without going 3 millimeters, it's retained very well. So maybe only doing distal bone grafting with that will be okay. Let's look at another simple case. I think it's a similar situation. The tooth was extracted too late, so there's a lot of fracture. So using residual bone, I only did the distal bone graft. And with the existing implant, I did also augmented prosthesis, and number 36, there will be another implant. So there could be a simple approach. Using the residual bone as much as possible is my point. Now, looking at this case, I think the focus is kind of in this difficult area. Can I place implant? So I'm not trying to encourage you, but if I tell you as is, as Dr. Park said, placing implant on the existing bone will be an option. Another one is creating bone where there is no bone, and then adjusting position could be another way. Since you say you are not very experienced, then this is not a difficult surgery. So if you have a good treatment plan, I believe you can achieve your goals. So I will explain more while looking at cases a bit later on. And Dr. Kim, now what I felt is that, these days, this type of peri-implantitis is kind of common. So looking at this case, what to do about the implant in the front, I'm a bit concerned. And even that implant, maybe removed and would be better personally. And also wisdom teeth is still remaining. And because of that, there is a residual space. So maybe that's why they placed a bit wide. So as Dr. Park, if you put it a bit too close to the bone, then maybe if you do that, then you have to extract the wisdom teeth or tooth. So how did these three masters solve these cases? Maybe Dr. Park, you can go first in terms of your solution. Actually, this is my curiosity, so I would like your input. Is the implant failed because of there is a dissemination, or implant failed and it became unstable, and that's why there was a cement wash? I don't really know. Looking at it, it's like chicken or egg first question, but I think looking at the case that was sent in, the graft materials are not in place. That means that, about 10 years ago, not this doctor, but other dentists did the surgery, and the GBR at the time was not very stable. And because of that, there could be some contamination, and there were bone loss as a result, and that's why it became unstable, hence resulting to dissemination. That would be my conjecture. I mean, don't know for certain, but I felt that the implant front and the back, they didn't place it simultaneously because it's in different design, and one implant failed and maybe was delivered again with new implant. Maybe that was the case. Well, that's very sharp. Well, I have asked that question because looking at this case, I think maybe implant was removed too late. So, I think that dissemination came a bit later. Implant failed first, and while it failed, the patient felt discomfort because there was mobility as a result of dissemination. So, not removing implant until the last moment is something I want to talk about. I have a similar, experience. This is not what I've done, but the biggest difference between the prior case is when implant was removed. So leaving implant until it is unstable and removing it can become really challenging. So you have to explain to the patient, even if the patient doesn't feel discomfort. So you have to take a proactive action. So, implant on the front side, I also want to remove it, as Dr. Kim said, but persuading that was not easy. So using smart brush, you do some treatment and cleansing, it would be better. But with the bone loss remaining as it and then delivering final prosthesis, I think it would not be very good. So Dr. Yang, in terms of peri-implantitis, what to do? I mean, you are expert in this area. I just use smart brush. Actually, when you talk about peri-implantitis, there is not only biological issues, but rather than looking at the cause, you also have to think about the prosthesis. Now, it's number 36. If you look at the contour on the distal side, now the prosthesis contour, is it, cleansed up or not, is something you need to think about. For number 37, there would be opened embrasure on the next to it, probably. And probably in this case, it would have been better when you create prosthesis, the distance, if it's wide, then the top part, like you have to create space where Proxa brush can go in so that there could be thorough cleaning would have been better. I mean, it was done very well, but cleansing up there or not would determine the prognosis of number 36. I think that is important. Yes, I'm learning a lot today. So another similar case, and I think another difference with the inquired case is that, was the implant failure first or cement wash first? I think for this patient, cement wash was first because the abutment is short and I didn't do any sandblasting and there is no groove. But patient came with the cement washout and came immediately after implant failed. So it just became a simple case. I placed another implant. What I want to say here is that patients, removing the implant because it's an extreme situation, waiting until then is not good. You have to remove it as soon as possible. That would be better. So here, it's a really bad situation. So for this case, preserving extraction socket would be good, but I wasn't confident about that, so I approached differently. There was a residual bone, and I did 3 weeks later bone grafting and delivered implant, and so that was a bone grafting and temporary with 2 implants. So for 18 months, then patient didn't come back. So then temporary broke. Maybe I created temporary too well, so it could withstand very long. So, but it has been helpful because it took time. I could wait a lot of time, and the conditions became better. So deliver another implant and final prosthesis after 18 months. This is CT I took. So compared to the initial challenging situation, it has become much better. So it's good if you could do socket preservation, but I'm not confident in that. So I wait until there's a soft tissue healing and then do bone grafting and deliver implant. That is the way I prefer. So even if you wait for this case, I don't think the bone will fill up. So for this situation also, you first do bone graft and I wait. So the bone is good form, so I didn't use membrane. I just did bone graft. So I have a question to Dr. Kim. So in this situation, soft tissue closing is easy, but without bone grafting, just covering it with resorbable membrane, what would happen? Just isolation. So the soft tissue would be removed, but only covered with membrane. So, and just let it fill with blood. I think it's possible, but if you are opened up anyway, and to make it more predictable, filling up might be better. But for this case, in the past, I would have used Autobone, but nowadays, as Wall is okay, allogenic bone, using that might be good. So I was curious, what would happen if you just fill it blood? Yes, anyway, thank you for that answer. Now, after 4 months, it filled with the bone very well. The bone was good. And another thing I want to say here is that the bone seems to form well, but don't use bone grafting as much as possible. Use residual bone as much as possible. That will give you better result. So you place implant where you can use the residual bone better, and then deliver final prosthesis. So if I may also ask another question. Now, placing implant on the grafted bone or leaning toward your kind of the patient own bone, what would happen? Would the result be the same if you place even 6mm implant? Well, actually, you augment with the bone grafting, but patients, if you use patient host bone, you will give you better result because bone grafting then remodeling doesn't finish, within 6 months. So even after that, due to different reasons, contamination or peri-implantitis, if that happens, then the host bone and then grafted bone, the reaction will be different, in my opinion. Hence, if possible, the host's own bone, using that, I do believe is very important. Thank you for that answer. Then, another case, a bit different case, there was a lot of bone resorption, so I could not place implant immediately, waited for 3.5 months, but still, not enough, so I did bone grafting for CT, looked okay, but in this case, I didn't use membrane. And when you don't use membrane, because, whether you use the auto bones or whether it was filled up very well, there could be other factors, but on the buccal side, if you don't use membrane, the grafted bone quality, I believe, is a bit lower. So another question here. So what do you think? Now, when you only do bone grafting on the buccal side, if you don't use membrane, would that play a role? Because bone quality doesn't look good. About the bone quality, I do believe article is already available. If you do only bone grafting, yes, bone is generated, but when in terms of using membrane, in terms of new bone formation, it's better for quality if you use membrane. So in terms of quality, using membrane is more favorable. Of course, there's a primary closure, and within the bone, within the defect, there could be bones, yes, but if you look at before grafting, there was no buccal plate. So if you put particular plate there, would the bone stay stable there? On that question, I think it would be helpful if you could use membrane. So viewers looking at our cases, please use membrane. That would be my recommendation. But anyway, luckily, it healed very well, and final prosthesis was delivered, and it's been 3.5 years, and it's been maintained quite well. And after 3 years, 6 months, this photo, so it's a panorama photo, but it's clean, and even on the CT, there's not much change you will see on X-ray. So this is another, it's a very extreme case. For this patient, now had a dental insurance, so have to wait for 2 years. So as is, it was really bad before 2 years, but, persisted, just stayed for 2 years. So it was difficult situation, but same bone grafting, and, after extraction, 6 weeks. So in case of buccal side like this, I used resorbable membrane, and using membrane, I always had a better bone quality. So for this extreme case, you do bone grafting first and then deliver the implant. So grafting and then doing implant, I do that because it's easier. If you do other ways, implant and then grafting, I think it's more challenging. And then final prosthesis was complete. Of course, there's a lot of bone resorption, so position is not that good. So I had to use custom abutment, but compared to where we started, it was really good. And number 37, I also did bone grafting first. So even with just bone grafting, using membrane, the bone form being given not very good, it can have a favorable result, and compared to the beginning, it's much more stable now. So summary. Now, number 37, single implant, is it possible? On the question, luckily, it's far away. So for this case, I think waiting for 8 weeks and then doing surgery, I think it might be feasible. Residual bone needs to be used as much as possible. I think that is the important point. That's more important than bone grafting. And, bone grafting and then waiting sufficiently and delivering implant again, I think will be easier. And as Dr. Kim Kyung-won said, extracting number 36 would make it easier. And what I really want to say is that if there's a problem with the tooth or implant, remove them as soon as possible would make everything much easier. That's it. Thank you very much. Yes, Dr. Park, thank you for asking a lot of questions. Yes, I learned a lot. Then Dr. Kim Kyung-won, please. Well, for me, I think for the inquired case, in terms of socket preservation, you know, using membranes for grafting or not was the question. I don't have much experience socket preservation, so I think Dr. Yang can answer that. So I actually talked about similar case and looked at the past cases, and I looked at the one case where the autogenous block bone and block bone was used. So this is a 2005 patient. So on number 36 and 40 was missing, and number 37 was missing, and I could place implant immediately. And for number 47, the bone quality was bad, and the inferior nerve was too close. So on the second panorama, on the ramus side, autoblock bone was removed, and on the extracted socket, as an inlay graft, I filled it in, and from there, after time, like this, about 5.5 months later, you can see it's healed. And then 8 months later, I placed it. And he was really busy person doing his own business, so didn't come to the clinic often. Came after 2 years, after autobones, about 1 year, 10 months, but it was retained very well. So in the follow-up period, after 2 years or 5 months, actually on the back side, number 47, on front of it, number 6, started to go bad. And after about 5 years, 8 months of surgery, number 6 became really a problem. So it even hurt number 7 where we did bone grafting. So we extracted the tooth. And on that extraction side, actually block bone graft was what I thought, but the patient, removing bone was really difficult, so he wanted another option. So looking at the CT, after 11 months ago, the bone graft implant is retained very well, but if you compare to the opposite side, as there was an infection in this area, the bone, alveolar bone inside, there's a sclerotic changes compared to the opposite side. So there is a defect, and the patient really did not want to remove his own bone. So allogenic block bone is what I use. So for this patient, on number 6, allogenic bone grafting was done, and then about 5 months later, implant was delivered. And now what I feel is that compared to autogenic block bone, allogenic block bone has its own constraints. But fortunately, in the follow-up period after that, there were other implants that were placed. But in the last follow-up, it's 2017, and first you had the autogenic block bone, and for about 12 years ago, and then allogenic or block bone 10 months later. So the implants is maintained quite well. But if you look inside, allogenic block bones, bone quality is a bit inferior. So for one patient in the very adjacent area, autogenic block bone and allogenic block bone were all done. So for this case, as I said before, collagen mixed material is not what I often use. So I often use, autobone or allobone grafting. So for this case, number 36, after removing that tooth, as you can see, there is a defect. And on that side, I did bone grafting. On the extraction socket, on the bottom side where you touch the hosted bone, allogenic bone grafting was done. On the top part, more genogenic bovine was covered, and the collagen membrane covered, and then placed implant. And prosthesis used quite well. I didn't, but could not find the photos. But for me, so if I do socket preservation, I often use, sandwich graft or layered graft between allobone and bones using them. So I think very similar case to the inquired case is what I recently done. So let me share that. for this patient, it's July 2021, so very recent. It's a very young patient. He is 35 years old and had an implant 7 years ago. But discomfort, there's no pain, and implant was not shaky, but there is a swelling and inflammation. So that's why he came to me. And looking at the CT, there was a really wide implant. And number 37 and number 36, alveolar bone has been fractured, or especially on 36. So if you let it be, the bone will only go worse. So as you can see here in the bite force on the ceramic is also fractured. So I saw the gingiva was very much swollen. So the decide to remove 2 implants. So it's an implant that's been loaded for 7 years, and also integration is still there. So it was not easy to remove. Then I could not use EFR kit. So let's look at the video. It's a video of the surgery. And as you can see, when you open the gingiva, there is a bone defect. And I put in elevator, but it didn't move. So inevitably, high-speed burr was used. So possible the cortical bone, I tried to not touch that, and then removed one. And for 37, it didn't move also. So again, high-speed bar was used. But the bone later was removed more easily. Unfortunately, there was some bone removed, but the lingual plate was not destroyed. So osseointegration is still very good. And then allogenic powder bone chip was put in, and then on top of that, genografting with the bovine bone, and covered with the collagen membrane, and you could say it's a socket preservation. So that's how the surgery was done. So for me, as I said before, looking at this case, the implant that was on front, I've been a bit concerned, because if you only do the backside, what if the front one becomes an issue? So like this, 2 implants removed, and then they're using the allograft and xenograft thing, and then the collagen membrane was covered. So it's a recent case, so I didn't place the implant again. But on the lingual side, there is a cortical bone. Then that's when you need to remove them. As Dr. Park said, when you decide to remove it, then as soon as possible, removing is much better than wait. And I think if necessary, maybe for the inquiry case, you do bone grafting first. And in terms of bias collagen, Dr. Yang could talk a bit more about that. Dr. Kim Kyung-won, you removing the big fixture or implant, you used high-speed burr? Yes, for that type of case, you have to retain the existing bone. But this is a really wide implant. So with the EFR, I could not really remove that. And it's also because there is osseointegration. So, but I remove implant quite a lot. So using a very sharp Fisher bar with the long burr. So close to long implant fixture, and not to damage your own bone is how I approach it. And in extraction also, elevator going in and trying to grab bulk room would be easy. But here, number 6 was hard to remove because there was a bone resorption. So elevator could not really, hook something. And 7, I just hit it, and there was a bulk room when the elevator went in, so it was easily removed. So trying to you removed it quite easily. I could see that smoothly. Thank you. So Dr. Yang? Well, for me, as 2 dentists really talked, or masters, explained very well. We looked at, different cases, but in the inquired case, what to do when the bone is not filled. I'm going to focus on that. On number 47 implant, there's a bone loss, and whether to remove implant or not, basically if it's more than half of the bone loss compared to the fixture length, then you removed it, because then managing it becomes difficult. For Dr. Kim's case, I would have removed 2, because if it's too thick implant, then certainly it's going to be a problem. So bone loss continues, that is obvious. So in that case, be it buccal or lingual, if there's a one still kind of alive, then remove it and try to form a bone there. It might be better approach. But for this case, based on your own principles, our own principles, we had to remove it, so removed it. And if you look at inside of the implant, it's a typical peri-implantitis. On the buccal side, you see, if you press, then there will be some pus coming out for sure. So after removing crown, using EFR kit, removed implant, and in that situation, so you looked at the bone defect. Nowadays I don't open flap a lot, but at the time I opened the flap, and as a inquired case said, Bios collagen and membrane also was used. Again, biocollagen was used, and I could use one whole chunk, but I did not that. I divided. I put one on the plate side. There was no lingual plate, so I put one on the lingual plate. There was no buccal plate, so place one on that plate too, and also one in between. So you can put in just big chunks, but if you can also do that in terms of that divisions. Though depending on the defect, you could just put one in, or you could also divide it up and put it in. In this case, I divided up, and after covering the membrane, I sutured, and after a time, it was healed. So if you see bone status, there's compared to bone loss, you see bone forming. So in that case, you can deliver implant very easily. So is it socket preservation or bone grafting? There are different terminologies used, but when it comes to socket, you could also say socket augmentation, but we need to say that this is from the wider meaning, it's bone grafting. But you can do after extraction, or after extraction, as Dr. Park said, you wait until soft tissue heals. So dentists, whatever is easy approach for you, you should just opt for that. So this is implant delivered, and as you can see, within the bone, you see it's healed quite well. So very simple implant delivery, and patient is not coming back. I think no good is a good news here, because he's not coming back because there's no discomfort. So implant was removed, and you can do like this, but the inquiry case is implant has already been removed, and then whether you do socket privatization or not. But I think the exact term is whether you want to do bone grafting or not, because the tooth has already been extracted. So looking at this case, there is an endo failure, and the tooth was removed, and you can see if you let it be, would it heal? I think, are you going to let it be, or knowing that it will not be healed with the extraction? Are you going to do socket preservation, or you cannot do soft tissue management? So after 6 or 8 ways of extraction, do bone grafting. So there are very similar cases like that. It's a 2014 paper from Seoul National University. After extraction, the bone is not being filled. So after removing implant, like inquired case had no bone filling. So here, buccal and lingual plates are still there, but inside the cranial tissue, there is a bone. After 9 months and after 12 months, still no then rather than just waiting, I believe that on the left case, you could maybe wait because the plate is still there. But on the right case, after 12 months, there's no filling and there's also no plate. So you have to take some action. So in this article, if you remove it due to periodontal reasons, the bone might not be filled. In that case, after extraction, you have to take some action. That's what the literature says. So it looked at the status. So in the extraction socket, it needs to be healed, and it didn't heal. What to do? That was the focus of literature. Then you have to do something. So for that case and this case, if you apply that into inquired case, waiting would not help the situation. So proactively, if the soft tissue is healed with opening of the flap, you remove things in there, and as two doctors said, if you do bone grafting, I think it will be easy later on. So for this case, number 35, would it fill up? There's no lingo or buccal plates. It's just, there's no anchor. Then maybe grafting first would be better. So here it doesn't really look there's a problem if you look at number 35. But after extracting, a perio situation not very good. Then I didn't use BIOS collagen. I only use BIOS. BIOS, and then the membrane was used. I mean, this is something I use a lot now, but at that time I didn't use membrane, but had used only primary closure. And then later, a different method was used, but after that, if you take CT, plate, and contouring can be visible, and based on that, there was healing. After that, based on prosthesis plan, other tooth was removed, and if you open the flap, the bone has been filled quite okay. So, if use the procedure that you're familiar with and confident with, and be it socket preservation or bone graft after healing, if the bone will not be generated, then preemptively, I think grafting should be the option. So what should be the judgment criteria? How would you know the bone will fill or not? In my opinion, as I said before, there are different tips. If you buccal plate, the lingual plate start there, and there are periodontal issues, then there will be no bone filling. So you need to do something. You have, there was CT taken. So I think there will be no filling there. Then preemptively bone grafting would be better. And in the acquired case, seems that there is a bit of graft material there. So remove them all and put in new graft material would be better option. For the BIOS collagen and, I cannot name product names, but Genografts collagen-based graft material, using that or doing just Genograft, comparing the two in terms of contouring, having collagen is easier, but there's a price issue. And if you cannot opt for that, then just doing Genograft, there will be no problem. But the second question was, sorry for naming product name, but Osmon collagen and, whether use Osguide, I cannot tell you because I also do not have experience. But if it's commonly generalized recognized material, it will be okay. But depending on the company, different results can be obtained. For some cases, even for same Genograft, there's a porcine, equine, or bovine. So depending on which type, different results are there. So the best option will be, if you could give me details, then I could also post my answer. So ask people around you, might be better. Because naming product name, I'm a bit cautious about that. So I hope for your understanding. Well, thank you for that. Now, if I may ask you to summarize today's talk. Dr. Park, well, I learned a lot today. So as Dr. Yang has said, there should be your own criteria when to remove it and which procedure are you going to use it, something that you are familiar with, and applying that in a similar situation, make it your routine would be best. Yes, I have a similar case. For this inquired case, as I always say, it's you place implant first. So there was no treatment plan because there's a too wide distance between implants, and because of that, the procedure contour for cleansing up could not be made, and the GBL was also not done very well. So due to these complications, the result was failure. So again, implant, you first have to have a treatment plan, and based on that, the procedures that I'm comfortable with would give you the most predictable results. And looking at this case, I think the inquired dentist would also have thought a lot. So I think for me in that situation, because wisdom tooth was still there, and that's why the implant became that way and the other procedure came that way. So for me, I would because of number 37, the implant, if the implant positioning that I'm delivering the new implant, it would change the position. So I would think about that and, use the best option that I'm comfortable with and is easiest for me. Now, let me summarize today. Discussion. Number 37, single implant. Yes, you can place it, but if possible, position and all the considered removing number 36 would also be better. And in terms of predictable socket preservation, now using membrane would be better. And I think in terms of contouring, collagen would be good. But if you want the product name, ask offline. And lastly, I have a question to Dr. Yang. You said many times, it's good if you can cleanse the prosthesis well. But for patient, you have prosthesis that has not much of a room. Then in that case, there could be gingival inflammation, but the bone is not resorbed, but there is a discomfort for patient. Then what could you do? For me, actually the prosthesis, whether it's cement type or screw retain type, it will be different. If it's screw retain type, then you could remove it and contour. But if it's cement type, then it's not easy. Then in that case, very cautiously, soft tissue without damaging it, embrasure, high-speed bar, I use that. Then sufficiently you can clean it. But the soft tissue could be lacerated, so you have to be very cautious because on the X-ray, how much contouring you can done needs to be determined first. So soft tissue, after contouring, it fills up again inside. And if it's filled not again, then you could say, use, interdental brush. Otherwise, if there's a discomfort, then you could do it again, maybe. Well, thank you for that. I'm learning a lot today, too. Anyways, that's it for this case discussion session. I hope it has been helpful to you. And I'd like to thank you, viewers, for watching this session. And I would like to thank 3 dentists for their discussion. And this has been Kim Se-jin, and I'll see you next time. Thank you very much.
감사합니다.
감사합니다. 수고하셨습니다. 수고하셨습니다.